Good morning. Welcome. We're glad you all are here. We are going to talk to you about pediatric rehabilitation medicine. I am Maureen Nelson. I do pediatric rehab. I've done it since before this one was born. And in fact, her dad and my big brother were friends growing up. We just met in person today, but we've been connecting for a couple of years otherwise. So I just came back to Austin. I was here before, then I left, then I came back because Texas Children's is opening here. Texas Children's was actually my first job in Houston way back in the day. So I was very excited that Austin was having a branch of Texas Children's, so I was excited to come back. I've been taking care of kids with brain injuries from all different etiologies for ages and ages and ages. And so what we want to do is talk about sort of from ICU to getting to adulthood. So we're going to go over a spectrum of things.
My name is Cristina Sanders. I'm also a pediatric physiatrist and I work at Texas Tech University. My goal, this is my first year at the conference, but my goal is really to be a resource for you all, to partner with Maureen and explain what it is that we do and maybe how we can help you. We do have a presentation. It is by no means something we have to get through. So if you have any questions or something that you really feel called to inform us about, please do. And if we don't get your question answered, we will stay around at the end. And we do have a table in the lunch area. So we are just here to help. And thank you all for coming. I know it was a difficult decision.
Oh, and if anybody lives here, this is the new Texas Children's. It's going to open on February 1st, so we're very excited.
February 1st?
Yeah, we're excited. Okay.
So I want to take a minute to kind of explain what it is that we do. My dad actually doesn't even know what I do. It's kind of hard to explain, honestly. So I just want to give you an idea of what you may hear about in terms of the type of physicians that we are. We, both Maureen and I, went to medical school. We then completed a residency specific to physical medicine and rehabilitation, where you learn about various motor impairments like spinal cord injuries, brain injuries, amputee, and really anything that affects the movement of adults and children. We then went on to do additional training to care for children, which is another 2 years. So we are here to be a resource for you. And what we do as physicians is what we call a subspecialty. So our specialty is physical medicine and rehabilitation. Our subspecialty within that is pediatrics. So we prefer to take care of children. We can also take care of adults, but don't remember that part. So pediatric rehabilitation medicine is, like I talked about, a subspecialty that combines prevention, diagnosis, and management. So it's very unique within the field of rehabilitation medicine because we actually want to get to know you and create a relationship with you that will be more lifelong. So this is not similar to surgery or emergency room management where you're going to see someone in a moment and then you may not see us again. A lot of times for children that develop in a non-traditional way, we function very similar to primary care or your pediatrician in helping you manage those movement differences as well as functional differences as your little individual goes from teeny tiny to really big. Because the brain works differently for everyone and that can present different challenges throughout a lifetime. I am going to assume that all of you are comfortable with reading the slides up here, so I probably won't read them to you, but if you do need some clarification or you have some questions, please let me know. Actually, just let Dr. Nelson know. So this is how we get to where we are. I'm super proud of this symbol over here on the far left because it means I took a test and I passed it and it cost me a lot of money. but this is who we are. This is what we do. And I know that Dr. Nelson feels this way. This isn't really a job for me. I love this. My family is involved in this. My patients are involved in this. It is just so important to me that every child experience joy, that I really want to stress to you guys that we are here to help you. So we go by a lot of names, which can be confusing. Physical medicine and rehabilitation is often acronymed into PM&R. So you may have heard of that from somewhere. You may have seen a PM&R physician. You may have seen a rehab physician. There are not very many of us throughout the country. You may have not seen one of us, but we are referred to actually by all of these names, so we'll take any of them. It's kind of like mom, mother, all the ways that you could say it. So I tend not to use the term rehab physician because then you do end up with some like alcohol treatment center type referrals. But any of these are familiar to us and we will respond to you. We are sometimes confused with psychiatry. This is physiatry, meaning physiology, the study of movement. So we are trained to watch you move. So if you catch us staring at you, it's because we can't help it. And what we are really focused on is function. What is unique to our specialty is we don't focus on one area of the body, and this is why it is so cool, because we get to help you or your child get to the goal that you have for them. And it may not be in the same way for each child, but it is about sitting down with you and your baby and problem solving. What do you need from us? How can we help? Is there an increase in tone? Is there seizure activity? Is it difficult to get up the stairs in school? Do you need a different education plan for college? All of these things are things that we are trained to assist with. I think we're pretty good at it, but it's fine. You can decide. So we actually use all the systems of the body to do this because we're not, as individuals, just about our parts. We're the sum of a whole, and our body works together. So that is the goal of our training, is to meet that together. So kids like to injure their brains, maybe not on purpose. It just kind of happens. It can be a little, it can be a lot. But this is one of our main areas of training. We see a lot of pediatric brain injury. And brain injury can actually be described in two classifications. One is a traumatic injury. So this is an injury where there's a specific, what we call insult to the brain. Can you guys think of examples of that? Right. Right. Yeah. No, actually, yeah. So like, I have seen children where, the automatic trunk comes down on the car where they get bopped on the head, baseball bats, football, and, things that are really like specific to one area of the brain. Non-traumatic injury involves when the brain is damaged kind of from within. So this could be a stroke. This could be something that involves the whole brain, encephalopathy, seizures, those types of things. But they all fall under brain injury, and that is what we help treat. So it's good. It's good. It's a good combination. Yes. Yes. Mm-hmm. Yep. So this is just a little bit of bragging, but I wanted to give y'all an idea of other things that we treat. So this is not actually for you. I know, right? The font is size 2, yes. But these are examples of different types of diagnosis that we do see. So I will just read you a couple. You may read them as well, yes. So muscular dystrophies, muscular disorders, what we call myopathies, different genetic disorders. So I don't want you to think that you only have to come and see this type of doctor because you have a brain injury. It can be because your left leg doesn't work well, or you're falling a lot, or you're weak, or you're tired. And if we can't help you improve that, we will get you to where you need to be to do so. We also take care of spinal cord injuries. So sometimes when you when you injure the brain, you also injure the spine. Like you said, getting run over by a car can do that. Some traumatic injuries are caused from car accidents, being in the car, being ejected from the car. Occasionally you can see a brain injury that also has a spinal cord injury, less common. And then what we call non-traumatic injuries, again, these are diagnoses in the medical community where we may be of assistance. Some are genetic, some can develop over time. And so this is just to give you guys an idea of what we do. We also do pain management. So we're also trained in the difficulties around the initial injury. For example, someone with a brain injury or a spinal cord injury may develop scoliosis. They may develop some hip dysplasia. We are trained to manage that in a non-surgical fashion. We are not surgeons, but we do work with orthopedic surgery. We do work with neurosurgery to improve the overall function of the body. And if I really like a surgeon, I'll tell them that my job is to keep my patient away from them. But we joke about it nicely. We all play nice in the sandbox together. So these are some of the concerns that come up in our field of study. These are things that we look for. One of them is debility. And this is a physical conditioning that results kind of from that injury. For example, no one gets well in the hospital from laying there. So sometimes you have things that come up in the hospital that maybe didn't start with that original injury. Anything that causes impairments, this is really important. This is kind of what we were made for, what we were called to do. It can be little, like crawling, walking, more of a pediatric setting, but we're also taught to assist with adolescents and adults. A lot of times it's hard for parents as their children grow up because when they're little, they can be carried. You can get a hip or you can get a stroller, and there's a big difference between 2 years old and 20 years old. So we are here to help you with that, to provide advice and resources based on the research that we have done and the training that we have had, both past and in the present. It's also not specific to isolated movement of muscles. We're going to help with what we call ADLs, activities of daily living, toothbrushing, hair combing, setting up therapies, maybe getting you to a center that assists with therapies, not only to just make your life a little bit easier by finding a better way to do something, but also to allow your child or your tiny child or your adult child to be within the world. This is very important because a lot of times when we have an injury, the world doesn't slow down for us to help us get better. And as a result of that, there's a lot of social and withdrawing of relationships. And so we as physicians can actually help with that, and we want to help with that. And our goal for being here is that you know, one, where we are, and two, how we can help. So if you get nothing out of this today up here, just know that you can come and find us and we will help you get to where you need to be. This is what we do, and this is who we do it with. So you can kind of link these in a left to right fashion, if you will. So, yes?
Sorry to interrupt you, but
please do.
This just recently got brought to my attention that even though Isaac wasn't severed in the spinal cord, that there could be injury to the spinal cord.
That is very...
How does that work?
So without going into specific detail about him, and not being able to review charts or anything like that, the spinal cord is a very large nerve. It's like even larger than your pinky. So it sits in a fluid, a clear fluid called the cerebral spinal fluid, and the nerves branch out into the arms and limbs. So besides actual cord like cutting or direct injury, if there is swelling in that area, or if there is anything that presses on the cord, because it's an electrical signal, that can be interrupted. So it is. We would love that. What there is not a lot of research on is very similar to alcohol and pregnancy. We know that alcohol is not good for pregnant mothers, but as physicians, we can't tell you whether it's 1 drink or 100 drinks. The same is the pressure on the spinal cord. So once there is pressure in some way, that cord is affected. Some spinal cords will immediately recover with that pressure removal, and others will not, because that signal has been disrupted. So it is about the process of the recommunication of the signal and the ability of the body to do that.
Also, you were talking about hypoxia as the original thing, and so the brain and the spinal cord are connected, and so this big nerve is coming from the brain, obviously, and so the same lack of oxygen to the brain, it's possible there's some impact on the spine, but again, we have no idea about your specifics.
It just blew my mind because I never thought spinal cord injury.
Yeah. And our body is all connected. So sometimes it's really hard to remember that. Yeah. Yes, ma'am.
Branching off of that, because I never thought of it either. And you said pressure and this might be like a broken bone, like would that create the pressure even without actually severing and creating a full-on like spinal injury, but still cause damage?
I don't know if I can directly answer that. My brain is fragmenting into many situations where that may occur.
Okay.
But what I can tell you is when you have a trauma to the body, especially a long bone fracture or a vertebral fracture, the body knows that something isn't right, and it will send different cells to help with that. And sometimes just sending, that response to heal creates some pressure and some swelling. And so that is possible. Many different types of scenarios, though, in where that would occur. Yeah. So we're going to focus a little bit more on kind of where you're going to find us now on this right-hand side. We actually are not hiding from you. After we go to medical school, we complete 6 years of training after that. So there are not many of us that graduate each year with this specific area of expertise, and we are growing that. But there may be one of us in one city, that kind of thing. And my goal for this is that you just know where to look for us, okay? Especially if you're bringing candy, that'll be fun. So we are in hospitals. So mostly, I would say, Maureen, I know you'll correct me if I'm wrong, mostly children's hospitals. Because we are pediatric trained, but there are adult physiatrists. Don't put that in the video. There are adult physiatrists in adult hospitals. One of the things that is unique, I think, about our subspecialty is we are trained to see children who grow up into adults that were injured or developed in a non-traditional way. We are very, very familiar with that management, so you don't necessarily have to leave us as providers when you turn 18. In fact, I feel like many college students would argue that you need to stay with a pediatrician till 26, but it's fine. We can talk about that later. So we are in what we call acute care hospitals, where you're injured, you're sick, you are rushed to the hospital. We are present in that facility. We can also be present in a clinic setting. So after the emergency, after the quickness of that hospital stay, we can be present in the office setting, and we can help with that transition from hospital to the community. We are also in sometimes a procedural setting, so performing injections, evaluating for braces, wheelchairs, and it really depends on the hospital system and how they design that. We do a variety of procedures, both what I would call interventional, meaning that we're working, to create an outcome involving a medicine, an injection, that type of thing. Sometimes we assist on surgeries called selective dorsal rhizotomies. We manage intrathecal baclofen pumps, which are an implanted pump that regulates medication, and we can talk about that later. We're also a lot of times the coordinators of equipment as well as therapies. And so our visits are sometimes longer, 30 to 60 minutes, and we really take time to get to know you. So it may seem like more than 20 questions, but we want to know how we can best serve you. Your turn.
Okay. So basically when we think about, taking about what we do, like Cristina was saying, it's just, work is fun. I talk to my friends who I went to school with, who see adults and like they're retiring, and it's just like, it's really fun. So we think about the job of children is to play and to learn. And so I think, that's one of the really great things. That's what we get to work with. So we're just trying to say, how can this child learn so that they can become a functioning adult, and how can they have fun while they're doing it? So we want to make sure that,
Sorry, I can't hear you.
So we want to make sure that, we have things as fun as we can. So my colleagues who are adults sort of make fun because I have my coat full of toys. I have some kids who I've seen for a while. They'll ask for a toy that was, that was there before, that's gone now. I have this one little girl was so hilarious. One day she told me I had my toys in my wrong pockets. It's just kind of amazing. So we're very into just making things as fun as we can for the kids. And again, just thinking, and our job is to go, okay, so here's this child of 6 months or of 2 years or of 7 years, but our job is to think about when they're 25, when they're 55. And so we want to sort of be in the present with a thought for long term, just like you guys do as parents every day. So what we want to do is to just maximize independence. And that's like every step along the way, is try to make sure that kids can do what they can do, and to stretch them and let them do more and more all the way. And we're going to be using adaptive equipment many times for that. We want to have the appropriate adaptive equipment, but the least we can do. So we think about, just whatever a child can do, and then just something else to make them do just a little bit more, just like, again, with any child. We also want them to be comfortable. A lot of stuff that's going to go on, some is going to be uncomfortable. There's, some therapies, there's some injections, there's this and that. But my thought about it is, I would rather do those injections because I know I can do it really quickly, and I can make it as fun as possible, and I can play with them as soon as we're done, and have it be just not this terrible experience. So where you have kids who, are happily come back to the office because, they know it wasn't that bad. Always making sure the kids are safe, of course, again, just like you guys do every day. And then, going through getting opportunities for school and for we'll go ahead. So again, what Cristina was saying, we're there from sometimes the emergency room, depending on your situation. That's not that common, but from the ICU for sure. So if your child's in the PICU, we're probably going to be there. We're going to probably be seeing your child and seeing what can we do to, first of all, make them comfortable. As she said, we're pretty good with pain management. And so we'll be saying, how can we make sure that as they're going through this, they're as comfortable as they can be, that it's, again, just trying to make things as peaceful as possible in all regards. And so we're going to be taking care of pain management, spasticity management early on. And if there's agitation or irritability, we work with that a lot as well. And again, as she was saying, we're going to be working with the therapy team so closely. We'll work with PT, speech, with rec therapy, with everybody who's there. And then we're going to be doing a lot of bracing, which will vary throughout the time frame. Working with equipment and meds, and we'll talk about that. This is a picture from a camp that I was at recently. And it's a camp with children with all kinds of diagnoses, but it was a lot of fun. So hopefully we're talking about those things. This also is at camp. This is a climbing wall that some of the kids could do, some could not do, and some could do with assistance. But so we're going to talk about physical exercise. Physically, anybody doing things, it helps us do it better. So we want children to be able to be doing things physically to strengthen themselves generally for all activities. But again, we want to make it as fun as we can, having things like a climbing wall to have them improve. So we think about neuroplasticity. How many of you guys have heard about neuroplasticity? Yeah, most everybody. So that's the ability to have new things formed. You've all probably heard the fact that we use 10% of our brain. And so what can we do to use, if we have a brain injury, what can we do to use the remaining portion? The younger you are, the better neuroplasticity you have available to you. So if I have a brain injury, I'm not going to do as well as she's going to do, and she's not going to do as well as these little ones are going to do. So it has that flexibility of your brain. One of the things I want you guys to keep in mind is there was a kid who I met when I was doing my fellowship training. So that's after residency and before you finish. And I saw this kid, and he was a volunteer at the hospital, really pleasant, like 20-year-old young man. And he had been a patient at this hospital where I was doing my training. He had been on the inpatient rehab unit. So one day, my attending was showing him and I his CT of his brain. So if you can imagine, so here's the brain. This much of it was empty. So there was like an inch around the edge of his brain that was left. And he's sitting here talking to me and talking to the kids. It's kind of amazing. Everybody's different. Every brain is different. That's not a general kind of thing, but just an example of you never know. Just got to keep that hope going and seeing where you are, okay? Sure.
Okay, going back to neuroplasticity. Now, I do know that it's like, okay, we can start using places of our brain that we weren't able to access prior to injury or insult.
Right.
Is that just, I guess what I'm asking is, I'm seeing a lot of cognitive function come back. So I would say like neuroplasticity and the cognitive function, but can motor tracks be built out of that too?
Well, new motor tracks can't be built, but can there be connections? It's possible. Again, it's different to say, clearly he's like Mr. Charmer because he's like smiling, interacting with me and making faces with me. So, but like, are there going to be specific neural tracks? There's not going to be new ones developed, but can there be new connections made? Yeah, there can be. And there's limits, and the tough thing is for all of us is that there's not such specificity in the, in imaging, in any diagnostic testing to know this is how much can change. That technology is not yet available. But I can tell you, technology that's available now is so much more than when I first started practicing. So it's going to continue to improve, as is technology then to work with that. So, it's a really challenging thing, impossible to specifically answer. But yes, we can in some cases see some motor changes. Okay. Sure. So we want to take advantage again, just doing those physical things. We don't want things that are that someone's not doing something. The studies are pretty clear, and Dr. Sanders will go on this later, that it's when we do things that make us improve. It's not really just the things where you're just sort of sitting there. So we want as many things happening physically as we can. Because again, physical things even help us, cognitively, not just motor-wise. So if we can be up and moving, that helps with cognitive development, with language developments as well. And for all of us, it sort of makes us feel better when we move, right? So there's a lot of work going on in just regular classrooms saying, gosh, We should have kids have little exercise breaks to help their brain grow. So we want to have that. And it also just, again, emotionally makes you feel better, gets a little bit of endorphins going. And so that's good for all of us as well. So the rehab team, this is a little canine in training to be an assist dog. So a rehab team, if you're on a rehab unit, so hopefully if someone has a brain injury, most times they're able to go to a pediatric rehab, inpatient rehab unit. And in that case, there's going to be a case manager who helps the parents just organize everything, get insurance, get things set for going home, which we start planning for as soon as someone gets there. We start planning for them to go home. And that includes planning sort of anything they may need in the home, equipment and outpatient therapies and all kinds of things. The nurse, of course, is key. That's your like link 24 hours a day. Social worker is a great resource that works usually closely with case manager. Physician is us. We're working with the whole team. Hopefully there's a psychologist as well, because there's a lot going on. I will talk later about other things we do. And the most popular member of almost any team is the dog. So if you have pet therapy, that's amazing. It's great for the patients' families. It's great for the team. Having a dog is almost always a great thing. Occasionally, I've actually had an occasion where a child was injured and was in the hospital because of a dog attack. We were very afraid of that, kept the dog off the unit until we worked with the child, had the psychologist work with the child, and luckily was able to get that child to love that dog that we had on the rehab unit, which then eased their transition back to home, which was huge because dogs are so many places, in fact, including in that child's home. Child life specialists, hopefully you guys have seen those as well. In almost every pediatric hospital, at least, there's going to be child life specialists who help have therapeutic play. They help play that is first of all fun and also then helping with growth and improvement. Again, hopefully also there's a teacher in the inpatient rehab unit so that when children are able to, then they'll be able to do whatever schoolwork so that they don't fall too behind and help transition back to school afterwards. Recreational therapist also is just someone who can help do different activities. Chaplain in many circumstances, not all, can help with the family in all spiritual kind of ways. Pharmacologist is very important because if you have a brain injury that's severe enough to have to need an inpatient rehab stay, then there may be a lot of medications that we work with to try to do. And the thing about medications that we use many times for the brain is that if you get in contrast, for example, if you have an infection, it's very specific what antibiotic, what dose, for how long. It's not as specific for the brain. I'm sure some of y'all have seen trying this medication at this dose, then this medication at this dose, and this combination. So there's a lot of work because brain injuries are so individual, it's very tough to do the research, unlike a lung infection or a finger infection. For those, it's very easy to research to see exactly what you need for how long. And for brain injury, because there's so much diversity, it's much tougher to study and figure out which is the exact best for each person. Of course, then the therapies, as we talked in, the family is the center. In rehab, one of the big things is it is a team, and the family is the center because you guys know those children so much better. So the parents and the siblings are like the most important members of the team. Dog's still probably the most popular for most of them. So again, the therapist, you guys are, I'm sure everybody's familiar, the physical therapist working on strength, on balance, on getting a coordination, getting moving going, whether that's crawling or walking or standing. And so they're gonna be working like crazy with everyone. The OTs, again, strengthening, getting the arms, getting the toothbrushing, the hair brushing, the helping with feeding, getting those coordination, and also just playing. Like, you know, how many times have we seen kids just like playing their games, and the OTs are great with that. And then speech, doing cognitive stuff, working on language skills, also working on feeding skills. And a lot of kids have problems with handling their secretions, with drooling, so they work a lot with that as well. Doing some things, sometimes kids will have something called vital stim that works on that. And so those guys will be going. So again, as was mentioned before, spasticity is a huge thing that we deal with, our tone issues. Again, this is a picture from camp. So there's a lot of, I also just want to, we'll talk about camp later, but lots of options for fun. So again, sort of when we think about tone management, therapy is going to be number one bracing is huge, getting just in therapeutic positions that minimizes spasticity, doing stretching, doing massage, and working on proper positioning. You can see the little cowboy boots here that are our Texas and apparently non-Texas too form of bracing. Although she's now a Texan, but I don't know if you'll say it yet. Yeah. You see lots and lots of I see lots and lots of braces. The official name is orthosis. Oh, one of the things that's really confusing is so you guys all know an orthopedic doctor is a doctor who does bone stuff. An orthotist is not an orthopedic doctor. An orthotist is a person who makes braces or makes orthoses. So many kids will be going to an orthotist to get braces made for them. They'll be custom fit. For adults, a lot of times it doesn't have to be custom fit, but for kids, they're so tiny, they need to have it fit for them. And, we'll see what they need as far as their hands, their feet, a trunk, etc. And is this one of your relatives or patients on
Yes.
the barrel racing or just riding?
It is a barrel racing.
Yeah. So, she's very into horse stuff. So if there's any horse treatment questions, she's got it. But then we use as I said, we use tons of medications. And you can see by this list, like I said, not necessarily one size fits all. So so it may be by mouth, it may be by NG tube, it may be by G tube to start with. Baclofen is very popular. It's been used for a long time. Big problem is it causes sedation a lot of times when you're giving it in this method before you can get to a dose that's useful. Gabapentin is something that's really useful because it gives us sort of a 3-for-1. It helps us with spasticity, it helps with pain, and if at higher doses, it helps with sleep at night. Bless you. Diazepam and clonazepam are in the same family. Diazepam is also Valium, which got a really bad name way in the old days, but at low doses, it's really great for muscle spasticity. So if you start with low doses and gradually increase, and same with clonazepam, they're very good. Now, just to back up 1 second, most of these medications your body will become accustomed to or dependent on. We think about Valium, the big problem with that, it was like back in the 1950s, it was given to any woman with any complaint would be given Valium, and they would become addicted. But if you give little doses, the doses just for spasticity management, your body will become dependent on it, just like it'll become dependent on these. But what that just means is you have to taper it off if you're going to stop. But it's not an addiction. An addiction is a mental thing, not a physical thing. And in the doses we use these, it's not addictive levels. Dantrolene is sometimes used, not quite so popular anymore.
The dosage for managing spasticity versus a PRN to having to add it
For seizures?
Well, or for seizures
or spasticity.
High agitation levels. Are they significantly different? Because we don't have diazepam constant, we just have it as a PRN. So I'm just wondering if that dosage is significantly
Not hugely different. And I would say that the way you're doing is probably the most common because I think a lot of people have been afraid of diazepam again because it was just hugely overused in the old days and again in too high of doses. But at low, just, talk to your doc about it. At low doses, it's, and the other thing is we know the side effect profile so much better than we do a lot of others. It's pretty low kind of thing. But again, there is a risk. I've had actually somebody who had their medication stolen and sold because that's what it is. So for that matter, I like to use liquid better than pills. It's also easier to dose little ones. So you can adjust the dose really easily.
Then one more follow-up question for the Ativan. I hadn't heard that Valium could be used more consistently for spasticity. Can Ativan?
It's
We have PRN for both.
Yeah, I have not seen it widely used for spasticity.
Yeah, so because Valium or diazepam works on the GABA receptor, for example, baclofen works on the GABA B receptor. Valium or diazepam works on the GABA A receptor. Longer term research has shown that the Valium is not as effective if taken longer than 3 to 6 months. That this is what we're seeing now that we're not in the 50s and we can go back and collect all this data. So the difficulty with using these medicines for management, especially in a brain injury, is that it can create difficulty for the brain to form those synapses, like a cognitive impairment setting, because of the sleep and the sedative effect. So I personally don't use a lot of Valium for agitation. I don't know if you can speak to that. There are a couple other medications that have some research behind them, and we can talk about that more later if you like. It tends to work in the short term, but not as well in a longer term setting is what research is showing us currently in this time.
We don't like them.
Well,
Well, if you don't like them, then you don't want to think about them.
so the other thing that I just want to say that is really important is we actually, as doctors, are not here to tell you what to do. We have a lot of years of training and a lot of loan debt. And that is just to tell you like what we've researched and what we know so that it helps you. It's a little bit like Buffalo Wild Wings trivia. Not all the facts up here are going to apply directly to you, but we may be able to help you make a better decision by providing you with the education that we have learned by sharing that. We want to be a collaboration. We don't want it to be, doctor and patient. We want it to be, like Dr. Nelson said, a team, an effort. Whatever analogy you like, it takes a village. Those types of things. We are not here to say, this is what is best for your child. We're here to say, what can I help you with? And let's find this answer together. And it's not always a perfect science. There's a lot of art mixed in with the medicine because, like she said, no two brains are the same. You have the same child age, the same type of injury within the brain, and they will not recover in the same way. And that also makes it a little bit more challenging, but also really fun to go through that journey with you and figure out what works exactly best for your family and for your child. So.
Yeah, like you said, you don't like it, and that's the case many times. Like, okay, well, that's why there's this long list of different options. Dantrolene used to be used pretty much because it was thought to have an advantage because it's not acting at the brain, it's acting peripherally, and so you're like, oh, good, we don't want drugs that impact the brain, which most of these do, when someone has a brain injury or anything going on with their brain. Unfortunately, it can cause liver damage and other things, so it's not that it's not that popular, especially in growing children. It's more popular with adults because their livers are already grown. But again, for some period of time, it can be a useful thing. Tizanidine, also some people like that. Again, we sort of usually go through the list. This might work for you. This might work for you. CBD and THC are some things that are getting a lot of publicity in the last few years and a lot of research in the last few years. It's a little problematic because, unfortunately, the way that marijuana is listed in the federal registry, that it's in the same category as heroin, if you can imagine that. There's actually always somebody putting forth legislation to change that, and hopefully that will happen, because there's a lot of studies that show some good things for spasticity and for pain relief and many other things as well. My first exposure to this as something for spasticity was when I was a resident at the VA, and I had a patient who had really terrible spasticity, and he would go out at lunchtime and go visit with his friends, and he would come back and go, wow, my spasticity is gone. But obviously, if just going to smoke a joint is not the therapeutic approach to do it, there's medication ways to take care of this and to approach. So, and
Do not listen to her, buddy. don't go outside with your friends.
I just told him not to. But now there's, we can get this, and we can get really specific combinations of how much THC, which is the high part of it, versus the other parts of it. And so what we would really like is to see a lot more research going on with this to see what is the exact best with it. But right now in Texas, it's finally been available in the last few years. I've been prescribing CBD for several years, and with families who love the results for their kids. And the people who treat kids with epilepsy have been able to do that longer, and there's more specific diagnoses. It's very diagnosis specific in most states. Texas is now catching up, but depending on your state, check and see what's available and who has what that may be useful. Again, what I tell folks is let's try all these other things that insurance pays for first before we think about that, because here anyway, insurance does not pay for CBD. It's not terribly expensive, but it's not cheap either. And then artane and carbidopa levodopa are used for kids with dystonia. So with the kind of tone issues, that's not the, that's not the, do you know how to go backwards?
I like that you look at me for this.
or just, I just keep going forwards instead of backwards. Can you help me by chance? So I couldn't do anything with that. Oh, yeah, you got it. I think she got it. Yeah, so spasticity is something that's consistent. So if you have tone that's always going on, that's spasticity. It changes a little bit with positioning, but if you have something that it's like, oh my gosh, some days it's like totally relaxed and sometimes it's totally like this, that's dystonia. So it comes and goes. And also dystonia is going to be like totally gone when someone's asleep. It's going to be totally relaxed. So it's a little tougher to, gosh. Crazy, huh? Dystonia is intermittent. Yeah, it'll be totally relaxed when you're asleep, but then it can be really problematic when you're awake. And again, it's harder to manage, unfortunately, as well. So he's trying to hunt. Then and so there we go. There's a demonstration.
So we were just talking about how spasticity is a velocity-dependent movement. So when you have spasticity, as you move your arm, like if I do this for the next 5 minutes, you're welcome, nothing is going to happen, right? In theory. Might be fun. If you have spasticity, this muscle will tighten with movement. It will become tighter. Whereas dystonia is where the muscle prefers that fixed position. So if she's here and I try and move it, yes, exactly. It is not going to want to be in that new position. You also tend to see dystonia activate when the individual is initiating movement. So if they bring their arm out and then it stays there, right?
That's dystonia.
So in terms of classification, most cerebral palsy or acquired injuries that are diagnosed as cerebral palsy, most of them have a higher tone present somewhere in the body, whether it's dystonia or spasticity. What tends to happen based on how the brain sends the different signals to the spinal cord is you tend to be really loosey-goosey from your shoulders to your hips, and then you see that intertwining spasticity or dystonia in the arms and legs. What?
Can't change a diaper.
Yes. Also, you can have both. So it sounds like your physician has given you an excellent description of all the ways that those muscles are working. Mm-hmm.
So then, what is the uncontrolled movement called? I always thought that was spasticity, like when it's the kind of Dr. Hartley showing Eden.
Ataxia, isn't that ataxia?
So ataxia would be a wide-based gait where you kind of waddle like a drunken sailor. There are several types of uncontrolled movements, and maybe we should put those in here. I apologize. There is a what's called a choreiform movement, which is a little bit like a wiggly dancing movement. There is a hemiballismus movement. I feel like I'm at my board exam, where you may have a limb that it kind of looks like it doesn't know what it's doing. So like this one side may be doing this and the other one is like doing this. Or if you're like patting your head, rubbing your belly, where they're kind of disconnected in that way. So those are examples of uncontrolled movements. There's an athetoid movement, and that is kind of like a writhing movement, like a slow, I don't know. Without dancing, it's kind of hard. It's kind of like a wiggly type.
Yes. So spasticity is something that's consistent, and there's this whole group that are sometimes collectively called dystonic movements. But there, and that, like she was saying, there's like, I don't know, 8 of them or something.
Yeah, we name them in many ways to try and identify those patterns, because there are medications specific to those patterns that are more beneficial than others.
And then all of these, spasticity and dystonic movements, are sometimes treated with these focal treatments. So Botox injections, phenol injections, and now cryoneurolysis. We treat all of those with injections. So whether it's spasticity, whether it's dystonia, those can be managed. The problem is there's limited amounts that you can do. So Botox, probably you guys have all heard about that, and basically the way that and so what that does is it blocks where the nerve fibers tell the muscle fibers what to do. And by doing that, so if you're stuck tight like this, if we can weaken these muscles that are bending the wrist and bending the fingers and pulling the thumb in, and we can do that with Botox, then we can relax it so that the hand's not stuck in that non-functional position, and then have the therapist and you and braces working like crazy with that. Phenol, we used before Botox was available. That's a type of alcohol, and that theoretically lasts longer. Botox theoretically lasts 4 to 6 months, but you hope that you strengthen the other muscles and get bracing and therapy going, and the effect lasts longer. Phenol theoretically lasts about 6 months. You can only do that on motor-only nerves, not nerves that have sensory fibers. If you do, you can cause pain. So there's only certain nerves that'll be injected. And then cryoneurolysis is something that's pretty newly been explored for spasticity. It's been used for pain for a while, but then just in the last couple of years, they developed these little manner to inject them into the nerves. And basically what you do is you inject, sort of like you would do for phenol, and you go to a nerve and you freeze that nerve. And I don't know do you know what the stuff is? I'm not sure what it is. I don't know what it is.
I'm not currently.
It might be. Yeah, I mean, almost nobody does this now. So literally 2 years ago, I was at a meeting and heard about they're doing this in Canada. And now this year at our meeting, which is coming up in a couple months, they're going to be talking about it again. And it's now used in adults in the US, but one of our colleagues was saying he was going to be trying it. But it's very new, but people are really excited about it because it's not a drug. The literature that I saw was studying a couple hundred adults who had it. There's less than 10% of people had problems with pain or long-lasting numbness afterwards. And again, this colleague was showing some pictures of patients who had it, and it was really very impressive. Can't wait to see what the research is, and I'm guessing that you guys will hear this available in coming years. As of now, it's very hard to find, and again, there's not a huge amount of research at this point, but it's pretty exciting because there's not drugs.
Does it damage the nerve?
Yes.
Definitely.
It's temporarily damaging the nerve. So phenol is damaging the nerve. What phenol does is it destroys the nerve covering. And by doing that, the nerve then isn't going to be working for a while, so you get relaxation. Then it just improves over time. But what can happen eventually is if you do enough phenol and you destroy enough of that, then eventually you get scarring and you can't do it anymore. The thought is that because this is not a medication, it's freezing, that might not be long-term. But again, it's not been used long-term. It's hard to know if there's going to be problems that come up that are found. I don't know if you've ever just we use freeze spray all the time when we do injections. So I'm all the time spraying myself to show kids what freeze spray does. And I always just sort of joke around, if this stuff ends up causing cancer, I'm going to have it right here, because this is where I spray myself all the time to show kids. So hopefully we're going to know pretty quickly again, because then we don't say, oh gosh, first of all, Botox costs so much. We can't have too much because it's botulinum toxin. It's a toxin. We don't want too much in your body. It's not alcohol. So it's very big thoughts. Let me tell you, we're over time right now. We'll be happy to keep talking, or if you guys have questions, we can keep going. There's other things. Just jump for 1 second. Intrathecal baclofen, totally different from baclofen by mouth or by G2, because the doses are literally like 1,000th of the dose of a pill that you take by mouth or liquid you take by G-tube. So it does not have the problem of sedating you before you get the relaxation effect. So an intrathecal baclofen, where they put the little hockey puck size thing here that has computer program, has the baclofen, they wind a little tube under your skin, and then they have it in whatever level in your spine, depending on what's your level of spasticity. That's a very useful kind of thing for many kids. And the other thing is that I love the best is you get to try it before you have the surgery. So you can have a trial where they actually take this liquid stuff and put it in the space that surrounds your spine, and you guys get to see what happens. So then the therapists do measurements, and you get to see how do they do with feeding, how do they do with transfers, how do they do with whatever. So I love that. And deep brain stimulators are used for the dystonic kind of thing. So that's a thing that's been used a lot with like adults with Parkinson's, and it's used some with kids with movement disorder as well. So again, anybody, I think there's sessions starting, lunch starting in a few minutes.
We're very sorry.
Yeah, sorry about that.
We do have like half more slides.
Let me just see. I'm just gonna go see if there's anything exciting.
We don't want you to miss lunch, but
Yes.
if you do have questions or you want to see the end of this, I mean, I guess they'll just have to have us back.
Let me just say,
Part two.
make sure your kids have neuropsychological testing done for school planning. Okay, so that's something that's covered by insurance for you guys. It's something that would have helped all of us be more efficient in school. So I'm a huge advocate of neuropsychological testing. And also sports. There's all kinds of stuff available. There's theater available. I saw a guy out here who's got adaptive theater program that he's doing. Seen that been really useful for kids. Again, Dr. Sanders is really into the horse thing.
Physical therapy on horseback.
Yes. Yeah, aquatic is awesome. You know, first of all, it's just like so fun, and it's so great for your body. I think it's really, really good.
Yes.
So theater, sports, there's adaptive theater programs. One of that's around the country started actually in Peoria, Illinois, by my attending when I was a medical student. He was a developmental pediatrician who happened to love to do theater. He started a theater program for kids with special needs. It's amazing, and now it's in 50 cities, called Penguin Project. If you guys see that, it's amazing. There's one here, the guy's Jason's Theater. I just heard it just now. There's a bunch of different ones. There's actually college scholarships now to a few schools for basketball and for track right now. So if kids grow up liking sports and are using a wheelchair, it's an amazing opportunity. Again, we just want to get the kids doing the most possible.
We're really excited about this, so we will talk about it all the time. Before you all go, I want you to write down this study. Doctors got together and they did a review of all the different therapy treatments for children, and they did a green light, yellow light, red light system, and they put it all in a study, not only for physicians, but for physicians to share of what we have learned through research works the best. What we have learned may not always work so well, but does not seem to be harmful. And what we have learned is we're not really seeing what we want with these types of modalities. And so it may be in your best interest to try some of the green light things. One of these that I will touch on that is new from this study is movements that your child initiates is better than if we initiate them. So if you're going to a therapy center, may I use you? Yeah. If you're going to a center and I come on and I'm like, hey, how are you? Let's work on your arm, and I'm moving it like this, that is great. I'm getting some nice stretch. What I've learned from this study is that if I take something and I'm like, hey, would you grab this for me? Yeah. Can you grab this for me? And he does that the connections of the brain are, we won't give up on it, right? The connections of the brain make the brain in charge of the body instead of me doing that. Then his brain doesn't know what my brain is doing. I know what my brain is doing, sometimes dangerous. But I want his brain to activate that movement. So this is something that has come out of this study, is activated therapy movements, which seems kind of like, yeah, I should know that. But when I read that, I was like, oh, I'm going to stay out of the way more. You know, I'm not going to get in there and be so hands-on, so that that child can say, hey, I need to move my arm, send the signal, and work with those neural connections to move the arm. So there are many, many other things in this study. This is the green light, yellow, all that. This is a publicly available article. So I would just encourage you to be informed. Maybe some of you are doctors, maybe in the medical field. We can always learn to help ourselves and be our own advocates. So thank you all very much for listening.